Yeah, so we have the internal carotid artery. So the internal carotid artery is the main artery which supplies the anterior circulation of the forebrain. And this is where the anterior cerebral artery arises from. So the anterior cerebral artery, as you can see, there are two, and it supplies the temporal and parietal lobes. And the two anterior cerebral arteries, they are connected by a thing called the anterior communicating artery. All right, so moving on to the spotter. So going back to the label diagram from before, which artery, so for part one, does this labeled artery arise from? So just think about what artery it's labeled and where the artery comes from. So again, just directly message me your answer and we can talk through it afterwards. So you have 10 seconds. Yep, so the people who've answered so far have got it correct. Yeah, so it's the internal carotid artery. And the artery which arises from the internal carotid artery is the middle cerebral artery and the anterior cerebral artery. And we can see here the artery which is being labeled is the middle cerebral artery. Great. And so for part two, which type of vertebra does the labeled artery pass through? So think about the different types of vertebra which exist and which type of vertebra do these arteries go through. So again, you have 10 more seconds to answer this question. Yeah, so for all those who've answered, they have got it correct. So it's the cervical vertebra, and the cervical vertebra have a particular thing called a transverse foramen. And within the transverse foramen, we have the vertebral arteries going through and ultimately going into the brain, where they fuse together to form a basilar artery, which forms part of the posterior circulation. Now moving on to our strokes. So here we have the anterior cerebral artery, as indicated by blue. Now, the anterior cerebral artery supplies the superior and medial parietal lobes, and also some portions of the frontal lobe as well. So, we know it supplies the superior medial parietal lobes and portions of the frontal lobe. So the motor control of which part of the body is most likely affected by our anterior cerebral artery stroke? So the question is it more of the arms or is it more of the legs? So, which part of the body is most likely affected? Yep, so we're getting all the answers through, and everyone is correct. So it affects more of the legs than the arms. And the reason why this occurs is because, as mentioned earlier, the brain and the primary motor cortex, which is located in the precentral gyrus, is topographically organized. And that means certain areas of the primary motor cortex correspond to a certain area of the brain. Now, because it's the superior medial parietal lobe, that means the part of the primary motor cortex which innervates the leg is affected. And so therefore you have your lower limbs which are being affected. So you have paresis, you have paralysis and weakness of the lower limbs. And that can be shown within patients with strokes of the ACA. And also it only affects the contralateral side. So if my right anterior cerebral artery is affected, then I'll lose motor control on the opposite side, to my left side. And again, likewise, if my left anterior cerebral artery is affected, I'll lose motor control on my right side and my right leg. Other symptoms include abulia. So abulia is a disturbance of intellect and executive function and judgment. So this corresponds to the main function of the frontal lobe, which is being lost. And this inhibition to loss of appropriate social behavior. And that's also seen in frontal temporal dementia as well, because the frontal temporal lobes are responsible for appropriate social behavior. So the patient with this type of stroke will act quite socially inappropriate in certain circumstances. Next, we have the middle cerebral artery. So the middle cerebral artery is indicated here in purple, and it's quite a vast perfusion area. It supplies portions of the frontal lobe and lateral surfaces of the temporal and parietal lobes. So 3 lobes of the brain are perfused by the certain artery. And that causes contralateral hemiplegia, which means it affects more of the arm than the leg. So with the anterior cerebral artery, it affects more of the leg, and with the middle cerebral artery, it affects more of the arm. So whenever we have a stroke in the middle cerebral artery, it presents with a typical presentation of a classic stroke, where patients are unable to either have brain paralysis, but also there are other symptoms which are associated with middle, and that's your contralateral hemisensory deficits, and also heminopia, because part of the temporal lobe is affected. and also aphasia as well. And the reason why we have aphasia is because the Broca's and Wernicke's area are affected. And the Broca's and Wernicke's area is only located in the left cerebral hemisphere. So the Broca's area is only located in the frontal lobe, so left frontal lobe, and the Wernicke's area is only located in the left temporal lobe. So you only get aphasia in a left-sided stroke. And there are two types of aphasia. So we have expressive and receptive. Expressive aphasia is when the Broca's area is affected, and receptive aphasia is when the Wernicke's area is affected. But also we can have both of them affected. Then there's a conductive aphasia, where there's an impact, where there's a deficit, when there's a lesion to the arcuate fasciculus. And the arcuate fasciculus is a white matter tract which connects to Broca's and Wernicke's area. And whenever that's impaired, both of the functions will be affected. Next is the posterior cerebral artery. So the posterior cerebral artery is located most posteriorly within the occipital lobe. And so whenever there's a stroke within the posterior cerebral artery, what we expect is there to be visual impairment within the patient. As we can see here, there are visual deficits. So homogeneous hemianopia, that will only affect one side depending on what type of posterior cerebral artery is affected. What is homogeneous hemianopia? That's basically an entire visual field being lost. So you lose complete vision on the right side or left side of your peripheral field. Visual agnosia. So agnosia is the inability to recognize anything. So if a patient has a PCA, so posterior cerebral artery stroke, and they were to give them an object, they'll be unable to recognize what it is because your visual association area is affected. And also prosopagnosia. So as mentioned earlier, prosopagnosia is the inability to recognize faces. So they wouldn't be able to recognize anyone, and that will manifest as symptoms of confusion. Okay, so considering the three types of strokes which we have another SBA. So we have a 64-year-old woman with a history of type 2 diabetes mellitus who's referred to the stroke clinic, having difficulty speaking and comprehending the spoken language. Upon examination, the patient is unable to lift her right arm and fails to respond to a pinprick sensation. It was also revealed that the patient neglected letters on the right-hand side of the eye chart during an eye examination. So, given the stroke history, which cerebral artery is most likely affected? Just think about the symptoms which are being presented here, and think about which part of the body is affected, so the arm. So you have 10 seconds to answer this question. So options A to E, which answer is correct? Yeah, so all of you are correct. So C, which is the left middle cerebral artery. Why is the answer C? Firstly, we have the speaking and comprehending of the spoken language. And that means it's a left-sided stroke because the Broca's and Wernicke's area is affected because the patient cannot speak and they cannot understand what's being spoken to them. The patient is unable to lift their right arm. And as we already know, the middle cerebral artery has contralateral hemiplegia in the arm, whereas an anterior cerebral artery is responsible for innervating the lower leg. Okay, and then there's a failure to respond to pinprick sensation, which means that the parietal lobes are also affected, predominantly the primary somatosensory cortex, and therefore the spinothalamic tract and also the dorsal columns cannot transmit those modalities of the sensory modalities. And it's also revealed that the patient neglects letters on the right side of the Snellen eye chart. That's known as contralateral, and that's known as hemispatial neglect, which means that the patient completely neglects one side of the vision. And again, that's associated with the parietal lobe, and so therefore left middle cerebral artery is most likely to be affected by this stroke. Oh, hold on. Okay, now moving on to hemorrhages. So there are 4 different types of hemorrhages. We have the extradural hemorrhages, subdural hemorrhages, subarachnoid hemorrhages, and intracerebral hemorrhages. Moving on to extradural hemorrhages. So an extradural hemorrhage is a collection of blood that forms between the inner surface of the skull and the outer layer of the dura, also known as the endosteal layer. This causes an increase in intracranial pressure, which strips away the endosteal layer away from the cranial cavity. And that causes an increase in intracranial pressure, that causes a midline shift and tentorial herniation. Tentorial herniation means that because of the intracranial pressure, the brain has nowhere else to go. So it has to go through the foramen magnum, and it has to descend downwards. And these symptoms are immediate. So when a patient has an extradural hemorrhage, the symptoms manifest almost immediately, and there is no delayed onset. So in a patient with a suspected extradural hemorrhage, what would be the most characteristic CT finding? So again, you have 20 seconds to answer this question. So directly message me your answer. So if I did a CT head in a patient with an extradural hemorrhage, what would most likely be seen? What type of sign? How would the hemorrhage look like? So we've got the answers coming through. Yeah, so for all those who answered, we have a lemon-shaped bleed. The lemon-shaped bleed is indicated here with a possible midline shift, as illustrated by the CT scan. And that's because it's occurring between the skull, so the bony part of the brain, and also the most outer layer of the dura. And the most outer layer of the dura is the periosteal layer. Our next, the answer has already been revealed, but the next is subdural hemorrhages. So subdural hemorrhage is an accumulation of blood within the subdural space. And subdural space is a potential space between the dura and the auricular mater meninges. And this occurs because of a rupture in the cortical veins as they cross the subdural space and drain into the adjacent dural syruses. And because it is a cortical vein, it means it's a low pressure hemorrhage. And therefore, there are delayed symptoms, which means suspected patients with a subdural bleed should be observed overnight because it takes a few hours before the symptoms kick in. So how can a subdural hemorrhage be detected? As already seen on this PowerPoint, it's a crescent-shaped bleed. So here we have a CT scan of the head, and as indicated by the CT scan, we can see there's a characteristic crescent shape. And we have also an autopsy of the patient where we have accumulation of blood above. Next is subarachnoid hemorrhages. So subarachnoid hemorrhages occur typically at the base of the brain. So that's predominantly due to aneurysmal ruptures, so berry aneurysms. This causes the accumulation of blood within the subarachnoid space. And berry aneurysms are arterial swellings at the junction of arterial bifurcations. So here is an example of a subarachnoid bleed within the circle of Willis, and we can see it's the base of the brain. It's quite messy, but it essentially happens because of a rupture of a berry aneurysm, and that causes the accumulation of blood within the subarachnoid space. How does it present? So subarachnoid hemorrhages have a characteristic presentation. They have a sudden onset headache, which is a thunderclap headache, and thunderclap headaches are very severe. If you were to ask a patient to rate a thunderclap headache using the Socrates acronym, they would say it's almost a 10 out of 10 headache, which peaks within 1 to 5 minutes of a subarachnoid hemorrhage, and they can last a significant amount of time, usually for more than 1 hour. What else? We have neck stiffness and muscle aches. We also have a loss of consciousness, photophobia, so the patient has an increased sensitivity to light, nausea and vomiting, and also associated confusion, and also visual impairment too. The reason why there's visual impairment is because if there were to be an aneurysm in your posterior communicating artery, that aneurysm will compress the oculomotor nerve. And the oculomotor nerve is associated with, one, the movement of extraocular muscles, but also with the movement of the eyelid, and also with the pupillary reflex as well. And so if the oculomotor nerve is compressed, we'll have symptoms of eyelid drooping, but also an inability to move some of your extraocular nerves. So perhaps a potential cranial nerve, third cranial nerve palsy as well. So major risk factors of having subarachnoid hemorrhage is polycystic kidney disease. So patients with polycystic kidney disease usually have subarachnoid hemorrhages, and there's a strong corresponding link between that. Hypertension is another big, large risk factor. Smoking, age of more than 50 years, if the patient is female, and also if they have a positive family history of previous subarachnoid hemorrhages as well. Usually if they're first degree relatives, if it's second or third degree, then the likeliness of having a subarachnoid hemorrhage is quite slim. Okay, and last type of hemorrhage is our intracerebral hemorrhages. So our intracerebral hemorrhages usually arise from a rupture of an atherosclerotic small artery that has been weakened predominantly by chronic arterial hypertension. So essentially we have small mini arteries which are atherosclerotic, so they have a very small lumen. So the luminal diameter is relatively small, and that's generally because of increased risk factors such as a fatty diet and obesity. And so when there is chronic arterial hypertension, because of the weakness within the small artery, they rupture and cause an intracerebral hemorrhage. They're usually quite deadly, as we can see here. This is a CT head revealing an intracerebral hemorrhage, and that's an internal hemorrhage within the brain. And We have Charcot-Bouchard aneurysms, which are most likely found in articular striated vessels. So that's within the anterior circulation of the circle of Willis. And because they're very tiny vessels, they're very susceptible to being weakened by sclerotic plaques and chronic hypertension. And that can cause mini bleeds, and then you have large hematomas, which cause an increase in intracranial pressure. And whenever there's a hematoma within the brain again has nowhere to go. It's compressed within a restricted cavity. And the only way for that brain to go is either compress, and that compresses all the major centers within the brain, but also causes midline shifts or the tentorial herniations through the foramen magnum downwards. Okay, now so just to summarize what we've been learning in terms of hemorrhages, we have an SBA here. A non-SBA, actually, we have a normal question. So a 32-year-old man presented to the ED with severe headache, which started an hour ago in the occipital region. On history taken, the patient rates the severity as 10 out of 10, and has also found that he has diagnosed case of autosomal dominant polycystic kidney disease. It's observed during the examination that the patient appears to be shying away from the light bulb in the room. There is stiffness on the neck flexion, and neurological examination is narrow. He's got a high blood pressure, so he's slightly hypertensive. His heart rate is within normal range, and his temperature is 37.2 degrees. So, based on what we've learned so far in terms of hemorrhages, what do you think is the most likely cause of this patient's headache? So what type of hemorrhage has happened here? Yep, so most of you got the answer correct. Again, you have 5 to 10 more seconds. Yep, so indeed, it's a subarachnoid hemorrhage. Here we have a subarachnoid hemorrhage. So this is a CT scan. And here is an aneurysm, berry aneurysm, which is occurring at the base of the brain within the circle of Willis. And the symptoms which are being presented is severe headache, the positive risk factors is so diagnosed case of autosomal dominant polycystic kidney disease, and also the associated